안녕하십니까? 이좋은 치과 손영희입니다.
Greetings, I'm Dr. Songyong-hee of E-Good Dental Clinic. This time, I'm going to talk about cases where ridge split is done using ESSET kit. I'm going to talk about the clinical tips to do ridge split using ESSET kit more easily. We can solve many different cases using ridge split. I'm going to show you most typical case first. In the case of this patient, implants are placed in lower and upper left, and implants will be placed in upper and lower right. The ridge on lower right is severely resorbed horizontally. At a glance, you can see that the ridge is atrophied. Vertical releasing incision is not made. Horizontal releasing incision is made to reflect the flap. The gingiva adjacent to natural teeth, it is ideal to preserve it. I did a little bit of preservation, but I was not able to do it perfectly. I did not think it was imperative to do papilla preserving incision. Crestal incision and distal extension was done to place 2 implants. It does not perfectly fit the protocol, but I have been using this protocol for a long period of time. I factor in the amount of remodeling and adjust implant position to avoid alveoloplasty. Horizontal osteotomy is done. The saw is used. I don't use the 13mm, the biggest saw. I use a smaller diameter saw first to give indentation and gradually increase the size of the saw. This way, we'll be able to avoid the saw shifting from the path, which is a major problem. We'll be able to prevent deviation. 13mm saw was used. I do osteotomy first and do initial drilling for implant placement. When I do initial drilling, as you can see, I try to do it more lingually. That's why I form osteotomy first. I try to minimize damage to buccal plate. I try to do initial drilling more lingually. What comes to mind is, in the case of distal osteotomy, how more of horizontal osteotomy do we need to form from the most distal tooth? I believe I need to extend at least 7mm longer. If you can extend longer, that'll be better. Split will be done better and possibility of fracture will be minimized. You need to distally extend at least by 7mm to form horizontal osteotomy. ESSET kit is used in the order. There's nothing special to talk about. You always use it in the order. The RPM is under 50 RPM. You need to have patience and do it slowly. You should not think of doing it all at once. If it does not go in, you need to change to manual mode and do split very slowly, because doing split itself is causing strain on bone, and we need to wait until the stress is relieved. If continuous bony strain is applied, if it surpasses the limit of resistance, a fracture can occur. You need to do it slowly and cautiously. In the case of this patient, ESSET kit number 4 was used and implant was placed. If you look at the state of how implant is placed,
링구얼 플레이트만 약간 페어
It
들어가는
is a slightly placed lingual. Buccal plate is intact. This is the way I do it.
벽갈 플레이트를 최대한 보존하면서
I try to preserve as much of buccal plate as possible. The purpose is to preserve a lot of buccal bone. Lingual bone is important, but buccal bone is more important. I try to minimize damage to buccal bone and perform split. You can see that from the center point of implant, you need to extend
스플릿이
more by 7 millimeter to do split more easily. Healing abutment is connected and suture is done. This is post-op panoramic image and post-op CT. If you look at CT, you may think, why do we have to do it here? But if I did not do split in this situation,
않으려면 알베올로
I would have had to do a lot of alveoloplasty and removed a lot of bone.
따라서 이런 경우에도 어떻게
In this case, it's a great case for ridge split. I did not do additional bone graft. I just did healing abutment and sutured the case. The prosthesis.
보통 보철물은요. 그냥
You can just use a general prosthesis. You would
통산하시다면
wait 3 months of healing if you're concerned before delivering the prosthesis. This is at the time of prosthesis delivery and CT at the time. It is well maintained.
현재까지 잘 유지되고
27 months after surgery.
전과 후에
Panoramic image.
됐고요.
Today I've brought this case to talk about the lower right quadrant.
나머지 부분들도 다
If you look at the CT number 46 and 47, crystal bone is well maintained.
까지 잘 유지가 되고 있는 상태를
You can see that no additional bone loss or bone remodeling have occurred.
확인할 수가 있겠습니다. 자,
This
이 케이스가
is
가장
a very simple ridge split case.
있는 케이스가 되겠고요.
Let me show you another example.
보겠습니다.
In lower right quadrant, from number 43 to 46, there's distal cantilever bridge. As you can see, in number 46, there's root fracture. Number 43 doesn't really look good as well. On CT number 43, it looks very unfavorable. There's no buccal bone, and the ridge distally, it's very thin like knife edge. This is ideal. There is sufficient amount of cortical bone and it has marrow space and it has a wide base. Vertical height is quite favorable as well. This is an ideal candidate for ridge split.
자, 보시다시피
As you can see, number 43, it looks very bad. Crown fracture occurred. I extracted number 43 and 46. After extraction, there's root fracture in number 46. In the case of this patient, I did not do immediate implant placement. I waited until gingival healing was complete, so about 8 weeks. This is ridge form. It has knife edge. In the case of number 6, it has a wide ridge base. I think we don't have to do split here. Number 43, number 44, number 45. I decided to do split here. I'm going to give you a clinical tip to do ridge split more safely. When you do it, you need to do it slowly. This is imperative to prevent fracture. My recommendation is to use 20 to 30 RPM if you're going to use engine to do split. If you're going to do it with your hand, you can do it much more safely. How do you need to do it? When you're going to place 3 implants, you need to place it in the order of center, distal, and proximal area. When you place implant, doing it slowly is good. In my case, I rotate it twice in 90 degrees each, so it's going to be 180 degrees. It goes in by 1.6 millimeter. And then you wait 10 seconds, it is a time to relieve a strain applied on bone. And then you do some more. You don't need to do it by 90 degrees. So you rotate it twice and wait 10 seconds. Rotate twice and wait 10 seconds. When implant is placed, fracture can occur very easily. Therefore, you need to do it as slowly as possible. If there's excessive torque, you need to have a moment to relieve strain to prevent fracture. This is a way to relieve the strain applied to the bone. You should not place implant all at once. Implants have been placed. In the case of number 3, bone healing was not perfect. Membrane was covered, it was submerged, and surgery was completed. As for other areas, healing abutments were connected, and one-stage surgery was done. This is post-op panoramic image. In number 43, 44, 45, you can see the clinical image, the oral cavity, and CT view. The bony housing looks very nice. Bone will be nicely filled. This is after 4 months. A linear incision is made to connect the healing abutment. I did not open flap. If you open flap, the blood supply will be severed once again if you reflect the flap. The blood supply will be reduced, therefore incision was made and healing abutment was connected. This is at second surgery. Gingival healing. It took about 4 weeks. After 5 months, I connected custom abutment, and this is after prosthesis delivery. This procedure will have meaning if it has long-term stability. I did no bone graft. In the case of this patient, this is after 18 months and this is after 50 months. After 50 months, if you look at CT on number 3, 4, 5, and 6, remodeling occurred somewhat. However, the patient did not experience any discomfort and there was no inflammation and complications. In the case of this patient, number 7 is missing in lower left. If you look at the ridge shape, you can place implant, but when you place wide the implant, buccal or lingual bone will be damaged, especially in number 6. Not a lot will be left. In this case, if you do ridge split and forgo graft, I'm sure you'll notice once you get the hang of it, but things can get very complicated if you use GBR to restore the lower posterior. In other words, prognosis is unclear. If you look at the ridge, it's a slightly knife edge. There are other treatment modalities, but I chose a ridge split. This is what I wanted to talk about in this case. When I opened the flap, more so than thought, the ridge is thin. I made the decision that ridge split is the only treatment option. I proceed with horizontal osteotomy. As mentioned, I do not do initial drilling first. I do horizontal osteotomy and then proceed with initial drilling. Following the traditional way, using set drill is the same. Implants were placed. Split has been done quite favorably. Let's look at implant placement position. I'm going to magnify the image. I did not do alveoloplasty. The superior bone is very thin. The way I do it, in the case of TS implant, they say you need to place about 1 millimeter deeper. You must place the implant 1 millimeter deeper than conventional implant installation level considering crystal bone remodeling.
저와 같이 알베올로플라스티를
If you do alveoloplasty ahead and osteotomy and proceed with a split, if you're not going to do that, you need to place the implant more deeper. This is something you need to bear in mind. As for this patient, I was curious what's going to happen, so I did not do bone graft. I just covered using collagen membrane and did suture and submerged it. Use of membrane, it's really up to you, but using membrane shows more favorable outcome. You do not need to do bone graft for sure, but if you use collagen membrane, you get better result. This is post-op panoramic image. Implants are placed very deeply. You need to place it deeper. This is so that we can compensate for bony remodeling that's going to occur after the split. This is post-op CT. After 6 months. I did not do re-entry after 6 months by choice. This was when the patient came in. As you can see, I just covered using one layer of membrane, but bone overgrowth occurred. Bone healing was really excellent to the level bone overgrowth occurred. I struggled to find where the implant was placed. I thought perhaps this was because of collagen membrane. It was an excellent result. This is after second surgery. Panoramic image. Prosthesis was hybrid type. This was how it was closed. If you look at the panoramic image before and after surgery, it was placed quite deeply. Between number 6 and 7, if you look at bone level, you can see that bone level has been reduced. Even though there's bone regeneration, we need to factor in bone remodeling and place it slightly deeper. It is the concept we need to have when we use internal submerged implant. Let me look at this upper case. You can do it upper easily. If the cortical bone is very thin in the upper, then you will not be able to get good result. Number 24, 25, and number 26. In order to place implants in number 24, 25, and 26, as you can see, in number 5, there's a little bit of fistula. On CT, as you can see, it doesn't really look problematic here, but it's very thin. If the ridge shape is like this, ridge base is very thin. It's not ideal to do ridge split, but the patient wanted to do simple surgery, so I chose ridge split instead of GBR. As you can see, osteotomy was formed. Implants are not going to be placed in number 4, 5, and 6. Implants are going to be placed in number 4 and 6, and there's natural tooth in number 7. If it were lower, vertical osteotomy, it would have been imperative, but in the upper bone is more softer, so it's possible. You can think of it as ridge expansion for ideal ridge split. Therefore, I did osteotomy in number 5 as well. Final drill was placed in number 5 to prevent bone rebouncing, and implants were placed in number 4 and 6. It's placed up until the end. Implants are placed in number 4 and 6, and then set to drill is removed. As you can see, significant split here. Because there's defect here, management is necessary. It doesn't look problematic here, but as you can see, in number 5, graft was done because there was no other choice. GBR was done. Bone graft was done here. I tried doing bone graft in osteotomy gap. I wanted to see the result. I submerged it, stitch out. This is post-op panoramic image. In CT view, in CR, it doesn't look problematic. It looks good in the proximal area as well. I wanted to look how the bone change occurs. At 4 months after surgery, secondary surgery was done. In order to check what's going on, I decided to open flap and papilla preservation incision was done. You can see the regenerated bone here. Bone graft was done in osteotomy gap, but you can see a lot of granulation tissue and the bone quality of regenerated bone is not really good. Therefore, I believe you do not need to do bone graft. I recommend not doing it. Healing abutment is connected and suture was done. This is 5 months after when prostheses have been delivered. Yes, it could have been delivered sooner because the patient was using RPD in the lower, but due to patient's circumstance, it was delivered more slowly. This is panoramic image post-op and CT. Remodeling has occurred nicely. This is panoramic image and CT on number 4, 10 months after surgery. You can see the bone is well maintained. The main focal point is the thickness of labial bone and buccal bone, how stably it is being maintained. Using ESSET kit, you can do this procedure stably in the upper S wall. This is after 36 months and this is CT in number 4. You can see that there are no major complications. I'm going to share another case. After having provided bridge, if there's a problem in the posterior abutment, you would have to cut the pontic and extract the posterior abutment and place 2 implants. This is a case that we see very frequently. As for the pontic site, because of significant resorption, it may be difficult to place implants. There was bridge in number 35 and 37, but there was a problem with number 37 and extraction needed to be done. Cutting was done mesial to the pontic site and number 7 was extracted. As you can see in number 6, there is significant resorption. It's very thin alveolar ridge. In this case, ridge split is possible. Ridge split osteotomy is done, set drill is used. In number 7, it's extraction socket, so it's a very good site to relieve the strain. It's very useful, set drill is used, and it's split. I had no choice but to use a 4mm implant here. In number 7, wide implant was used. In number 6, a ridge split was used and it was placed. In number 7, it was immediate implant placement. Gap management was done. This was how they were placed. This is how ridge split was done. You can see all implants have been placed within bone housing. This is 4 months after surgery. Prosthesis delivery was done and the case was completed. This is panoramic image after prosthesis delivery. Number 6. So what would happen long term? This is panoramic image and CT after 34 months. It's quite thin. I think there's about 2 mm of buccal bone, and I believe that the patient will be able to use it long term. This is summary. When you use ESSET kit and do ridge split osteotomy, this can be utilized for different indications. The benefit of ESSET kit is that healing time is short. The necessity to use membrane and bone graft goes down. That's a major benefit. Even without complicated GBR, you can get favorable amount of buccal bone and lingual bone. In most cases, I don't do vertical releasing incision, therefore you can just do it with small incision. It's quite favorable in terms of soft tissue management and doing suture after surgery. So healing time for the patient is rather short. The surgery is quite simple and it does not require additional graft material and membrane. Therefore, post-op inflammation possibility is quite low because implant is placed in bone housing and has the benefit of osseointegration. You can get strong stability of implant very quickly. The amount of hard tissue inferior is increased and you can get additional thick attached gingiva. It has many advantages. The kit helps in making the ridge split technique more simpler and accessible. In this lecture, I've used the ESSET kit and talked about how it can be utilized and shared various cases where they were used. If you continue on this learning path and continue to practice, you'll be able to expand your expertise and know-how. This is the end of my lecture. Thank you for watching.